Hi, this is Sherry Shabowski, and today we're going to be talking about pediatric lumbar puncture. First, let's talk a little bit about why you might be sampling the cerebrospinal fluid. First, cerebrospinal fluid is a colorless liquid that surrounds and protects the brain and spinal cord. It's made up of water, sugars, proteins, lipids, and electrolytes, and it's very similar to plasma, except a little bit less protein and no blood cells. CSF cushions the brain and the spinal cord. It removes waste products and it provides nutrients. It also helps stabilize the brain's chemical balance and keeps it buoyant. The choroid plexus is where the CSF is made, and then it's drawn back in the subarachnoid spaces. Positioning. The child has to be positioned basically with the back out, kind of like a cat would stand, with its back all arched up high. You can do it with the child sitting and leaning forward, or you can have them in the lateral decubitus position. But just make sure when you do the lateral decubitus position and you have someone holding tight, that they're not holding too tight. It is not uncommon to have a child respiratory arrest from being held in that position for too long with the airway compromised. So keep it in mind. And put your hand on the child's chest once in a while if your LP is taking a while, just to make sure that they're breathing effectively. Scary, I know, but we don't want bad things to happen, so we have to be aware of the bad things that can happen. Here we have a picture of where you're going to put that needle. If you look at the posterior iliac crests, the very top of them aligns with the L4-L5 space, which is the optimal place to put the needle, especially in newborns. The reason for this is because the spinal cord ends about L1, L2 in adults, but it may extend down as far as L3 in infants. That's why you want to go to the L4-L5 space, so that you are in an area where there's a lot of CSF, but no spinal cord. This is a sterile procedure, so you're going to need to clean the area very well with chlorhexidine or betadine. Use sterile drapes, sterile gloves, and a sterile setup. Anesthesia might be something you want to consider, because clearly having a needle stuck into your back is going to be a little bit painful. In children less than 3 months, you can use oral sucrose. It seems to be very effective for pain relief, kind of, I think, a bit like a distraction for the child, but it works quite well. You can use topical anesthetics like Emla, but just know that it takes about 30 minutes for it to numb the skin. So you might want to prepare and put that on a bit before you want to start the procedure. You can inject local anesthesia like lidocaine, or in really severe cases or very difficult cases where you absolutely need the LP, you can consider IV sedation. But that would be a rare situation. Some people do their LPs and don't use any anesthesia at all. That's a little old school, and I don't think the children really appreciate that much. But the logic behind it is stick them with a needle once and do the LP, or stick them twice because you have to inject lidocaine before you put the needle in. Now, I just gave you a few options there that you can use instead of local anesthesia, so perhaps we should at least try something to make this procedure more comfortable for the child. Placement of the needle is important. You can use an ultrasound to determine the depth and optimal location. Remember that that canal is relatively shallow, especially in infants. And you definitely don't want to overshoot or be in the wrong space. If you go too far into the back of that space, you'll often hit the venous plexus, and that'll cause you to draw blood out of the space. That's not what you want, because that's just confusing and doesn't really help you to diagnose whether the patient has meningitis or not. It makes it more complicated. Before you go in, you want to make sure the stylet is secure. Many of the needles have a lock setting where you can put the needle in the exact lock space so that it doesn't move around. Then you want to find those posterior iliac crests and the corresponding L4 space. You'll place the needle against the anesthetized skin. You want to remain perpendicular to the spine and level. The bevels on the needle should be parallel with the cauda equina fibers. If you're in a left lateral decubitus position, you want the bevel to be up. If the patient is sitting up during the LP, the bevel will face the wall. You want to anchor near the skin and apply some pressure. You want to guide through those lumbar vertebrae slowly. Actually, you're guiding between the spinous processes. You'll feel a pop when you go through the dura, although this may be subtle. Once you get in the space, you're going to remove the stylet. You're anticipating that you're going to have CSF coming from the needle. If you don't have CSF, check the position. Make sure that you're perpendicular and level. You might, if you're sure you're in the space, you might want to rotate the needle slightly. Sometimes that will cause the CSF to flow. Also, you might be a little superficial, so you may need to go a little bit deeper. Also, the needle should be level. If the needle is kind of on an angle going upward, that's going to keep the CSF from flowing. So make sure the child's spine is level. Sometimes if the child cries or moves, the CSF will start to flow. Sometimes that crying is helpful. If you need an opening pressure, you can use the manometer that you see on the left, but you certainly can't put that much CSF in the manometer when you're working with a child. There are mechanical manometers that you can put on the end of the needle that can give you the opening pressure. Once the fluid starts to flow, you want to put about 5 drops in each of the 4 tubes. The 4 tubes are numbered, so you could keep track of which one is which and which one you got in the beginning and which one you got last. Normal CSF is clear like water. What you're going to check for is a cell count, because you're going to know how many white blood cells there are, and you're going to need to know the differential of those white blood cells. Additionally, you'd like to know how many red cells there are. If it's a traumatic tap, as you go through the different tubes, you'll have less and less blood in each tube. Chemistry is important as well, because glucose consumption is common with bacterial infections, and increased protein is common with inflammation. So that may help you to know if there's an infection. You'll also need a gram stain and a culture. Gram stain initially to see if you can actually see any microbes in the CSF, and then the culture to see what grows out. When you do an LP, make sure you get 1 extra sterile tube and put some CSF in there. CSF is like liquid gold. You don't want it to go down to the lab and the lab say, oh, we dropped that. Oh, it spilled. Oh, it leaked. We can't do that anymore. Imagine if it spilled. How you'd have to go back to the parent and say, hey, remember that LP we just did that made your child scream and look super, super uncomfortable? Well, someone screwed up in the lab, so we need to do it again. No, that's a very difficult conversation to have. And imagine you're the parent. That's ridiculous. So what most people will do is they'll take an extra tube with some drops in there just to make sure that they have at the very least enough for culture. Here's the finale. Now you're going to place pressure on the site where you did the LP. You are going to remove the needle with the stylet in. So once the fluid comes out, you replace the stylet. That stops the flow of fluid. Then when you're ready, you're going to remove that needle and place a bandage there. A little bit later, after you put pressure on the spot, You're going to come back and just make sure that the CSF is not persistently leaking, because that would not be great. You really want that CSF to stop leaking immediately after the needle comes out. All right, your job is done. Virtual high five, everyone. Thanks for listening.